Dr. Stephen Hardy is a plastic surgeon, and what you probably know is that he is here to talk about restoring appearance, breast reconstruction. And Dr. Hardy is a plastic surgeon with Northwest Plastic Surgery. And so we're very grateful for his gifts, his talents, his ability to help restore appearance after surgery. So join me in welcoming Dr. Stephen Hardy.
It's interesting. There are a couple things. I'm going to not jump into this talk right away because it's great sometimes being a member of the audience and hearing things, what people have to say, and listening to the questions, and sort of getting into the mindset, because not even sometimes, all the time in medicine, we just look at it from our perspective, what we know, and we get so used to it that we just look at life a different way. And it's great to hear people ask questions and say, they really don't understand what this is about, or it probably could be explained in another way or in a better way or something like that. And so I do just wrote a couple of things down that I thought I would go over really quickly, because Dr. Grimsley wasn't able to be here to talk about surgery. And I think that one of the important things to sort of just the basic concept of cancer surgery is, and I'm always trying to use analogies to try to make it more understandable, and I thought of one as I was sitting over there, that treating cancer, what you really need to do is you need to maximize your chance of getting every cancer cell out of there. And so imagine if we took in this room, the room was empty, and we had a big pan that was just, say, the walls of it were that high, and it was filled with mice. And there's a little chunk of cheese in the center of it, and we put it right in the center of the room, okay? Now the best way, and in a sort of a bizarre way, just think of those mice as cancer cells. And so if somebody said, quick, go in, we want to get all the mice out, the best way to do it would be to somehow collapse the entire room and implode it, okay? That would be sort of akin to doing a radical mastectomy. Just get rid of everything, and you'd be able to get all the mice. If you then said, well, couldn't we not destroy the room but find a better way to get all these mice under control, you would say come in and put a big sort of fence that had no holes in it around them. And the sooner you get in there and put the fence around, the less likely those little mice are to run out into the corners and escape into the building, or spread, so to speak. So if you can get in there faster, you can put in a smaller fence around those things. The later you get into the room, the more you stand outside the room and wait, the bigger the fence you're going to have to put in to try to contain those mice. Now, you never really know if the second that pan was put there, that one of them didn't scurry off somewhere and disappear into the bowels of the hospital. So the analogy of chemotherapy then comes into place, because you never know. And you could look at these mice and say, well, these are really active mice. So we're going to have to fumigate the hospital, like chemotherapy, to make sure that we didn't get any of those mice running around the hall somewhere, or stuck in the library or up on the third floor or something. So you want to contain those things the best you can, and the faster you get to it, the less aggressive you have to be about containing and getting them all in. But there are a lot of little clues, like looking to see if they are aggressive mice who are going to run around right away. And one of the nice things about treating cancer nowadays is that the early detection is so important. Like I said, getting into the room fast and containing them. And it's enabled surgeons to be less aggressive with their surgery. In the old days, any time before, say, the mid-60s, say early 1970s, the Halsted radical, as Dr. Snyder said, was sort of the accepted treatment, because people would show up with a lump. There wasn't this early detection. Mammograms either didn't occur or were exceedingly rare. And so patients would not show up to in their doctor's office until they felt a golf ball-sized lump. And that's really late detection. At that point, most of the time, people had spread. And so everybody was getting, and this Dr. Halsted, he actually was at Columbia, where I went to medical school and did my residency. So sort of Halsted and Hagenson was a guy who followed him. They were the two foremost breast surgeons on planet Earth, and they were both at Columbia. Actually, Hagenson lived in an apartment underneath me when he was in his 80s, which I thought was really amazing, that one of the most famous breast surgeons on planet Earth lived in the apartment below me when I was a medical student, and just in this humble little apartment on 171st Street in Manhattan. But anyway, Hagenson and Halstead felt that if you could just take everything around the breast, you could increase the chance of cure. And so at the time, that really worked. But as we got better and better at detecting things, we realized, well, you really don't have to take the whole pectoralis muscle and the pectoralis minor muscle, et cetera. You could just take the breast tissue. And so that became the modified radical. The radical took all of the muscle and everything. And they realized that as cancer was being detected early, as medicine was evolving and people were becoming more aware, women were doing breast exams and picking up their own lumps earlier, or mammograms were becoming more common, and they were able to detect things on mammograms. Their ability to detect was better. They realized that we could just do a mastectomy, just remove the breast, and still have as good a chance of cure as we did with the common Halstedian radical, where they would remove all the muscles. And then as time evolved, they realized, well, we could actually, if we just get that lump, take that lump out and then irradiate the breast, that would work just as well as a mastectomy. And I'm getting back to that mice analogy. That would be, well, we could wall off the mice, but then if we irradiate the whole room, any of them that kind of scattered around, we've probably gotten them all. And so that's sort of the thinking there, is that if you're going to do a lumpectomy, if you're going to take a small piece of tissue, you can't be certain that any of those cells hasn't spread around elsewhere in the breast. But rather than removing it all, the chances are small enough that if you just blast the breast with radiation, you're going to kill any remaining cells. And one of the problems with cancer is that it's a gigantic gamble. That's really what it all comes down to, is what is the likelihood that one of those darn mice hasn't scattered out of there right away, the second you put the thing down into the room, that it's gone and hidden behind the curtains and then scattered out of the room and gone somewhere. And you just never know. And that's why, and I also made a note to myself about when you'd asked about cure, because you never know. And it's one of the unbelievable ironies of cancer, is that you don't know that you've been cured until you die. And it's such a phenomenal, I was just thinking about it then, and I'd never really thought about it this way, but you don't know that one of those mice hasn't gotten out there and is running around your body somewhere. I mean, the longer you live, the more likelihood is that you know that you've passed it. But you never really know, and that's what makes it so scared. It makes you so scared. It makes the disease so scary, is you never know until the game's over if you've really beaten it. And it's a very bizarre irony about cancer, is that it's always going to be in the back of your mind. And it's something, and you can see why people are frightened of it. And it's really one of the last frontiers in medicine, if we could just find a way to control that. There's so many other things, trauma, it's unavoidable things, certain types of injuries, et cetera, that you can fix. But cancer is one of those things that you can increase. You think, I'm pretty sure we got it all, but you never know it's a cure until the very end. And you can look back on life and say, gee, I had it 40 years ago, and now I'm dying of my heart attack, but doggone it, I beat the cancer. And and it's just a very, very bizarre irony. So anyway, it just kind of came to me as I was sitting there. It's one of the interesting things about medicine is being able to sort of sit and listen to people and interact like that. And you're always teaching yourself, and it really makes it a lot of fun. And I also wanted to follow up on Dr. Snyder's comment that it's not fun seeing patients in the office for this. It's one of those things when I pull a chart off the rack and I look and I'll get this lump in my throat, like, oh brother, I would so much rather see somebody for the facelift or their eyelids or something. That kind of stuff, and I'd love to see anybody for that rather than for cancer reconstruction, because it's very difficult. It's a tough thing to, from my perspective, how is this patient going to deal with it? You have to, be very careful in talking about it, because they're so confused and everything is just being thrown at them at once, and it's really hard to digest all this. And sometimes I can tell that I'm talking to them, it's just going right over their head. And it's okay, and I understand that, and I always say, think about it this weekend, and call me this weekend, and we'll talk about it again, because it's so important to understand what's going on, but the patients are so overwhelmed all of a sudden. Gee, do I have a lumpectomy and radiation? Do I have a mastectomy? Am I going to need chemo? I mean, it's very, very difficult. So it's a tough job, and there's enough other stuff going on to keep us busy that we would much rather not have to see patients for this. There's plenty of trauma going around, and again, if people You don't have to worry about breast cancer. Let them live to get their facelift is the kind of way I look at it. And that would make me much happier. And hopefully, someday it'll be like that it won't be an issue. But for the time being, it is, and we have to deal with it. So in terms of how I look at reconstruction, first of all, when I see a patient, the most important thing I say to them is that I don't want, like say they come in, they say, well, I've got a lump, and I have to, the question is, do I get a lumpectomy and radiation or a mastectomy? And I always say, listen, I don't want any part of that decision, because it sounds very self-serving of me to say, wow, you probably should get the mastectomy, because then it keeps me busy. But I never ever want to participate in that decision, because I'm not the expert on, what are the cell markers on the particular tumor, what is the size, I haven't seen the mammogram, I don't know. I say, listen, you just discuss that with Dr. Snyder and Dr. Grimsley or Picard or whomever you may be seeing, and get that issue settled. But I'll tell you what we do in terms of reconstruction. Because if the lumpectomy is, say it's a small mass, and there's really a good chance you're going to get an equal cure with either the lumpectomy or the mastectomy, then go for the simplest thing for sure. A mastectomy becomes more mandatory with bigger tumors, or with what we see as multifocal tumors, and that's not unusual to see multifocal, say DCIS, ductal carcinoma in situ. So there's some things that sort of mandate performing a mastectomy versus a lumpectomy, but very often there's the decision of doing one or the other. Now, having a lumpectomy also doesn't preclude needing a reconstruction, because after somebody, they may have a relatively large lumpectomy followed by radiation, and it leaves a pretty significant defect in the breast, so then you do a partial reconstruction. And I'll get to that as we go. So hopefully, I kind of like having the lights on, but if these don't project well enough, we may need to, well, that's not so bad either. So when we look at somebody and deciding on how to proceed with reconstruction, first of all, when I say additional treatment, is the patient clearly going to need chemotherapy or clearly going to need radiation therapy? Very often you don't know that ahead of time. You don't know it until afterwards. But if you know it ahead of time, I'd prefer to wait. For example, if you know for sure that the patient has sort of a diffuse tumor, or it's multifocal, or it's close to the muscle, and they're going to require postoperative radiation, I would much rather wait and do a secondary reconstruction, because you want to get all the damage done and then fix it, rather than doing a reconstruction and then irradiate the reconstruction. Because radiation is it's wonderful, but it also has it really can injure. Not only does it kill cancer cells, but it kills your own cells, and it causes a lot of scarring, a lot of firmness in the tissue. It hyperpigments, makes the tissue much browner and more stiff, and so it's not as easy to reconstruct after somebody's had radiation. Their general health, somebody could be had severe heart problems and just not be a good enough risk to be on the operating table that long. Diabetes, high blood pressure, et cetera, et cetera. All these things have to come into play in the decision making, whether we use the patient's own tissues or use an implant for reconstruction. Smoking is a huge factor, and patients who are heavy smokers were much more likely to say, you'd be better off using an implant for a reconstruction than using your own tissues. Now, there are ways to sort of fool Mother Nature with reconstruction in a smoker, but the basic issue with patients who are heavy smokers is that smoking causes a tremendous amount of damage to the microcirculation in the body. And that the entire game of plastic surgery and reconstruction really it all has to do with blood supply. If something doesn't get oxygen, it doesn't survive. And it's really that simple. That, really should be like the title of, Plastic Surgery 101 kind of thing. If it doesn't get oxygen, it can't survive. And so we have to decide, and that's really what the specialty is all about, is figuring out ways that you can get a piece of tissue moved from one place to another and still survive. And so when we can sort of push the limits, so to speak, and I'll get into doing the belly flaps and the other flaps, but the point is that we want to transfer something and make sure it's getting enough oxygen. But if in smokers, their small vessels are clogged enough that the red blood cells can't flow through well enough. And so very often the tissue doesn't heal well, or it'll just out and out die. whereas it wouldn't in a non-smoker. Now, there are ways we can trick the body by partially doing the operation, letting the tissues heal, and then going back a couple of weeks later and doing the rest of it, because there's something we call the delay phenomenon, where if you make a series of incisions around a piece of tissue, you cut off some of the blood supply, but not all of it. What's remaining, the tissues will release certain compounds which make the blood vessels dilate and the circulation improve, so that you can then, as a secondary operation, completely do the transfer and the tissue will survive. And it's a little complicated, but it's something that you still can do complicated reconstructions in smokers, but it makes it much more difficult. So the options are using an implant or your own tissues. Now, to use an implant, what you have to do is you have to stretch the tissue out, because normally after a mastectomy the surgeon has removed a large amount of the skin, and so the chest wall is just flat. There's no breast tissue there. There's just muscle and a thin layer of skin over it. And so you need to stretch everything out before you can put a nice soft implant in. If you're just to pop the implant in, it would just feel very, very unusual, and it would not look very good, as opposed to the flap technique, which is where we take tissue from somewhere else in the body and transfer, and it looks more natural and it feels more natural. The other options that we go over is, do we do an immediate reconstruction or delayed reconstruction? An immediate reconstruction meaning that I'm in the room with Dr. Grimsley or Picard or whomever it may be, and as soon as they're done, I go ahead and I start my part of the procedure. Now, a lot of times when we'll be working together, that if we're doing, say, a belly flap reconstruction, while the general surgeon is doing the mastectomy portion, I'm down there dissecting the belly tissues out, so as soon as they leave, I can transfer it up and work on the reconstruction. The data does show that immediate reconstruction does not, especially nowadays with early detection and better cancer control, that an immediate reconstruction doesn't hide a recurrence to any significant degree. Now, and I've discussed this with the general surgeons on plenty of occasions, that if somebody has a rather large tumor, or if it's deep, I'll say, you know what? When I say deep, I mean it's deep down in the breast, close to the muscle, and so that when they do the operation, they don't know if they've gotten all those cancer cells. There might have been a couple that snuck away and have gotten into the muscle, and you normally don't take the muscle in a standard modified radical mastectomy. So if you're going to remove, when you let's see, how do I wanted to get back to the immediate versus delayed. When you know that you're going to have a tumor that's risky, you don't want to then cover it with a flap or put an implant in that's going to potentially hide your ability to detect a recurrence. And so in those cases, we'll just say, let's wait 6 months, a year, 6 years, whatever, and you can always go back and do it. One of the nice things about doing a delayed reconstruction is that the patient has had a chance to heal, and you really know what you're dealing with in terms of the patient's tissue integrity. Because on the operating table, when they've had the mastectomy, you don't know if some of that skin is not going to do well and die. Because part of the procedure of performing a mastectomy is cutting underneath the skin as closely as you can to get every breast cell you possibly can. And that leaves the remaining skin very, very thin, henceforth not a lot of blood vessels flowing in it, and so some of that skin can die. So there's always this concern about tissue dying, and we don't want to put an implant in if then, after we close the skin, the incision is going to break down because the implant's going to get infected, the tissue expander is going to get infected. So to us, actually, a delayed reconstruction is always a better scenario, but it's also kind of nice to have the patient wake up and know that they've had the reconstruction. So there are pluses and minuses to both, and it's such a long discussion. I don't want to belabor it, but just know that that immediate reconstruction doesn't increase the chance, or doesn't increase well, I shouldn't say increase, it doesn't decrease the ability to detect a recurrence. It really won't affect whether or not you're going to get a recurrence, but what you want to do is you want to be able to detect a recurrence. And so if you can, with the implant or with the flap, it really doesn't affect that when you do immediate reconstruction. And then the delayed reconstruction just allows you to sort of look at the landscape a little bit better and determine what you can have, what's going to survive, what's not, to proceed with your reconstruction and make decisions on, do we use a flap or do we go ahead and put an implant in. Now, I'll get into the specifics now. In terms of using an implant, what we have to do is because the skin is so thin when they perform a mastectomy, we can't just plop the implant in and sew it up. Because the skin is so thin, I kind of jokingly say you could read the implant label through the skin. And so you can't, you can't allow that to happen, because the implant will eventually erode through the skin and become exposed and infected and have to be removed. So we have to put it at a plane deeper, which means we have to put it underneath the pectoralis muscle, that big strong push-up muscle that some people have. Everybody's got it, but I'm not good at doing push-ups anymore. I'm getting a little too lazy. But you want to put it underneath the pec muscle, because it gives it muscle is a very, very rich blood supply. And so that pectoralis muscle protects the implant and gives you an extra barrier so that the implant won't get infected, and it gives a much more natural appearance. So putting a big implant underneath there right away is very, very painful, and it also that won't take on a very natural shape, but you can slowly coax that muscle to stretch out. And so we put in something called a tissue expander, which is an empty balloon type of device, which about every 2 weeks the patient will come into the office, and we'll give him an injection of saline through the skin into the implant. And I guess I'll have a picture of it in a minute. But gradually we stretch the skin to a point where the patient says, well, gee, that matches the other side. Or in the case of a bilateral reconstruction, they get to choose. They can stay kind of small or go pretty big. Now, of course, we don't want to go really big, because a big implant is just a nuisance. So, but it does allow us the ability to sort of determine, and slowly you can expand the tissue over a month or two or a year or two. And the reality of it is that the more slowly you expand, the better it works, because the body just adapts to slow changes much better than it does to rapid changes. The expander operation is less painful than a flap reconstruction, because we're just staying in one spot. We're not going into another area of the body. So it's a little simpler operation. The recovery is a little bit faster, because again, we're just not doing so much to the body. We're just staying in one area. So in a lot of patients who just want to get their life back fast and want to get back to taking care of the kids or their golf game or whatever, it's easier to do a reconstruction with an implant. And it's a nice way to go. And with the And you can ask questions about the silicone stuff later, because that's a whole different discussion in and of itself. But with the new silicone implants, which have been shown data-wise, they've been out for 10 years now, to be safe, that the reconstructions with implants are pretty darn good. And I'm much more likely now with these newer silicone implants to recommend an implant reconstruction than a flap reconstruction, because somebody can just get their life back together quicker, and it feels and looks very natural. This just sort of goes over. Is this a pointer, or is this just advances the slides? I guess it probably just advances the slides. But anyway. Here's a pointer on. Is there? Oh, here we go. Excellent. Thank you. So it's just an empty balloon that we put in. But anyway, this is a tissue expander, and this is just the area where you put the needle into and you slowly straight. This is sort of a partially filled one, as is this one, but I don't know if anybody's interested.
Thank you.
And then this here is an implant which goes in after the tissue has been stretched. And you kind of, sort of the best way to sort of evaluate, I always tell people, just put it underneath their skin and feel it, or not underneath their skin, but just underneath their clothing and feel it. And it feels very natural. So, okay. The downside of it is that it doesn't look as real, but with the new silicone implants, because it has sort of more of an ability to kind of drop like a natural breast does, it can look pretty good, and it feels much better, but it's still not as real as your own tissue, as your own fatty tissue that we use for a reconstruction. It's also a little bit higher. Again, it doesn't fall the way natural tissue does, a little bit higher and rounder, so it's not unusual for us to do a lift procedure on the other side, for example, to balance it. Again, the asymmetry is why we would, yes?
How long does it last?
Well, they're saying, there's no official party line on that, but generally most of us are saying 10 years. After 10 years, switch the implant out. And again, I kind of jokingly say it's sort of like tires on your car. Don't wait till you blow out a tire on the interstate. Change it after 75,000 miles just to play it safe. And it's the same thing with the implant. Don't wait till it breaks, don't wait till it's leaking. Just get it out after 10 years. Because the current silicone implants that are available, like the one that's being passed around, they've been out since 1998, and they've been very, very thoroughly scrutinized, and patients, and initially to get them back in 1998, everybody had to enroll in a study group. Nowadays, because I think it was a year and a half ago, they said, you don't have to enroll them anymore because the data's been good enough. But for the 10 years that they've been out, the failure rate has been less than a couple of %. It's pretty darn good. So there's like a 96% chance that the implant will still be fine without a leak at 10 years. So you could probably go 20, but again, like with the tire analogy, just change them. The other nice thing is with the new silicone implants is that it's a gel and it's not a liquid. So if the implant does break, it's not going to go oozing all over the place and causing problems. It's just, you could literally cut the implant in half and hold it upside down. It's just going to stay there. So the way that we have detected failures of the implant, a leak, a tear, whatever, is really the patient will just say, it just doesn't feel right. It feels funny. It hurts. And we take it out. I've had one patient who had a leak, and it was just a little pinpoint kind of leak, and there was no silicone anywhere. It was just this sort of, when I squeezed the implant, it's like this little bubble of silicone came out. So I think that the big concern about the silicone goo going all over the place, like it used to with the old implants, which were an absolute disaster. That's not really a concern anymore about it going anywhere. And also studies have been done about the incidence of fibromyalgia and other collagen vascular diseases. And it's been shown in very, very large studies that the silicone doesn't cause those things. Because I wouldn't want to use these implants if there really was a risk of causing some other disease. It just wouldn't be worth it. But the data has clearly, and I had never put in a silicone implant until just a couple of years ago. And when I finally saw that, when all this data started coming out, I said, you know what, they do look pretty good. And then I saw patients who'd had them, and I thought, these actually are pretty good implants. So I think that we're doing okay with them.
Does saline last 10 years also?
That actually has been studied, and the actual, if you were to plot it out, if you take 20,000 women with saline implants and you follow them for 30 years, it's a big bell curve in that there have been a couple of failures early on, and then as time progresses there are more and more failures, and then of course it starts to drop off because there are less and less people with the implants in because they've already failed. So you develop what's called a bell curve distribution. But the peak of that bell curve is 13.7 years. For what it's worth. But so again, with saline implant, the nice thing about a saline implant is that if it fails, you can wait until it fails. Because if it pops, you just get a drink of water, so to speak. It's just a little bit of saline that's in your body, and that's what your body's full of, is salt water. So you don't really have to change the saline, just because you just wait until it breaks, and then somebody will wake up in the morning and say, you know what, my breast is flat. I need to get but get in quickly though. I always tell them, because if it goes down, what will happen is the body will very quickly shrink back down around that space, around that failed implant. So you want to put it back in quickly. But fortunately, putting one back in can be done under local anesthesia in the office. It's a very simple procedure. So there are a lot of reasons that we will recommend implant reconstructions. Again, the other downside is that it requires 2 operations as opposed to 1. That you have to stretch the tissue out and then remove it and then put in the second, the nice soft either silicone or saline implant. That's just this kind of just describes things. I'm going to sort of skip over a lot of these things. And this is an early, some of these pictures, they're not the ones that I wanted to put in, but I had such a busy week in the office, so I asked one of my assistants to just pull some slides out and put them on the PowerPoint thing, and they're not what I wanted, but what am I going to start yelling on Saturday morning when I first looked at these? But this is not projecting very well, but this is the natural breast, and this is the reconstructive breast. And it's not quite as evident as it is on this picture. This is just sort of fresh after the nipple reconstruction. You can see there's the mastectomy scar there, and but with these newer silicone implants, you can start to get that sort of fall to the breast that it's so hard to match on the opposite side, as opposed to the salines, which tended to stay up a little bit higher. And it's kind of hard to see, but I think it's a great little procedure. It's something that we use. It takes about a half an hour to do under local anesthesia. You don't need an IV. We just do a little bit of tattooing, and you take these little little skin flaps and lift them up and wrap them around each other. I describe it as sort of like the tail of a fish. If you lift the tail of the fish up and you take those 2 little things and you bring them around each other like the yin-yang thing and that forms a little nipple mound, and then you just tattoo everything else around it. It's actually a really cool procedure, and it's just as a little aside, when I was a resident back at Columbia, when I was chief resident, I was doing a nipple reconstruction with my chief, Dr. Norman Hugo, who was a great surgeon and always a thinker. And back then, we used to take skin grafts from the groin or down in that area and to give the pigmented look. And I said, we did one. I said, Dr. Hugo, is that really necessary? Isn't there a better way that we could do this? I mean, it really kind of upset me that we had to do this for a nipple reconstruction. And again, it was just sort of like when I was sitting in the audience and listening to people talk, he had this, stupid resident ask him this question, like, why do you do it this way? And he said, you know what, I don't know. Let's think of something else. And so we went ahead and devised this tattooing thing and this way of making the nipple mound, and he really did most of it. I just kind of helped. But I got to write the paper with him, and we presented this, and I, as a resident, got to a free trip to Bermuda to present this at an international meeting. And I was like, oh, this is great. This science stuff is cool. You get free trips and get to go to Bermuda and stay at this really fancy hotel and stuff. So I'm very fond of the procedure, one, because we wrote it up, and two, is that it works well. It's a nice, neat little thing, and it goes very quickly, and it doesn't cause as much pain, et cetera. So,
Is that a saline or a silicone?
that's a silicone. That this reconstruction is, yes.
Doctor, when you started, I thought you were going to show us a pre-surgery set of breasts and then a post-surgery. I didn't realize until you started talking that it was post-surgery.
Yeah, this is, fortunately, yes, this is post-surgery, and this is what we aim for. This is kind of an average to good. Some of them are not as good. And what our biggest enemy is radiation with doing tissue expansion, because it really makes it very, very difficult to stretch the tissue out so that it feels natural and drops naturally. Yes?
Is that under the pectoral?
This is under the pec muscle, yes. And you can kind of tell because you can see sort of there's just not the natural sweep here, that the muscle is kind of pushed up. There are little clues that I can tell, how it's done. But in general, I mean, she's pretty happy with that. And when you stand in front of the mirror, it's not sort of that difficult thing of having to look at either nothing or no nipple present on the reconstruction. There, I actually have one set of slides or whatever, photograph of the patient without a nipple reconstruction. You can see that, oh boy, it would be so much better with a simple little nipple reconstruction. I went over the radiation thing. I'm not a big fan of doing implant reconstruction with radiation because the tissue is just not very pliable. So we usually have to use the patient's own tissues. In bilateral reconstructions, however, it's the best situation because one implant looks like the other, so you get good symmetry. There was a plastic surgeon once who said at a meeting, and it was kind of weird, but he's right. He said that asymmetry is worse than ugliness. And at first I didn't quite understand what he meant, but the reality of it is that if something doesn't look good, that's okay, but people really don't deal with asymmetry. And they hate that. I mean, if one breast is fallen and the other one is way up here, that people really don't like that. I mean, you could have two ugly reconstructions, but that's better than a normal breast and a good reconstruction if it's asymmetric. So when you're doing an implant reconstruction or in a bilateral reconstruction scenario, I'm much more likely to recommend doing an implant reconstruction because there's excellent symmetry. The other is that you're not beating the body up as much, taking two pieces of tissue, taking two flaps. It's very hard on somebody. And it's an operation I used to do, 10 years ago, much more frequently. But after a while, you start to say, it's not fair beating up these people like this with doing a bilateral flap procedure. It's something I rarely do now. And if I do it microsurgically, which just takes less tissue, but it's a much harder operation and whatever. And we'll get into that. So this is a bilateral implant. Now this is early on. This is one of the ones I was like, why did you put that one in? It shows a fresh scar. It's like, I don't want to make people. But the reality of it is that you got to see what you got to see. And the implants themselves, one looks like the other, and if you in probably 6 months or so, that pink scar will fade, and then it becomes a lot more acceptable. But it's a little bit difficult. It's it's an unfortunate thing, and it all depends on where the tumor is as to where the scar is. And on one side it may have been higher, the other side it may have been lower. One side may have been a prophylactic, where they do remove the breast just because of the high risk of having cancer. There's so many different scenarios, but with a bilateral reconstruction, it's always easier to do it with an implant. Now, getting onto muscle flaps, the advantage is that it's really just your skin and your own fatty tissue, so it feels very much like a breast, and you can get that tissue, you can sort of sculpt it, so to speak, to look much more like a breast than an implant, which is sort of, you can't make that implant do something else. It's there, and you've got to kind of somehow make the body fit around it. It's a longer operation for sure. It's much more painful, and especially the belly flap procedure, because we've got to dissect the belly tissues, it's basically what it is like a tummy tuck operation, where instead of throwing the excess skin and fat in the garbage, we keep it alive by keeping it attached to an artery and vein running through the rectus abdominis muscle down the belly here, that six-pack muscle that people have. And if you dissect that muscle out with the artery and vein that run through it and have little branches that run up into the skin, you can then tunnel it up and bring it up into the chest and make a breast out of it. The other way is to divide it down there and then microsurgically sew the blood vessels that go into that piece of tissue into the armpit or into some blood vessels off the side of the chest. And that's a very complicated procedure, but it also works. It requires more recovery because you're dissecting into the body. For example, when you put in a tissue expander, when we do the implant reconstruction, the first phase when we put in the tissue expander, usually the patient's in overnight, at the very most 2. When we do a belly flap procedure, they're in the hospital 3 to 4 nights, sometimes even 5, because it's tough getting immobilized because your belly really hurts. They usually say the chest doesn't hurt at all, it's the belly that hurts a lot. And so we've gotten to now where all the patients will get an epidural, which will help kill the pain in the belly, or help decrease the pain in the belly, so we get them moving faster so that they're less likely to get blood clots. But it's a tough operation, and it's not for everybody. There's something called the latissimus flap, where we can take some skin from the back and transfer that over to the breast based on the latissimus dorsi muscle, that sort of big muscle that you use to do pull-ups with. And that muscle has a very well-defined artery and vein, what we call a vascular pedicle is the term we use in plastic surgery. And the vascular pedicle to the latissimus dorsi muscle is very identifiable, and you just protect that. You make an incision in the skin over the muscle, dissect down in the muscle, and sort of dissect everything down, so you're now just off this little leash, and then you pass it through underneath a skin tunnel here to use it for the breast reconstruction. Now, normally people don't have enough fat on their backs to make enough breast to match the other side, so we usually have to use an implant in addition. Which is why the latissimus muscle is not the ideal choice for a reconstruction. It is the gold standard for doing a partial reconstruction when somebody has had a lumpectomy and radiation and they sort of have a quarter of the breast missing and it just doesn't match and it's sort of pulled up and scarred. The latissimus muscle is perfect for that because it's not quite as invasive as a tram flap, and it's a very reliable blood supply, and you don't need as much tissue. It's not overly bulked. The belly flap, called the tram flap. Tram stands for transverse rectus abdominis myocutaneous. And anyway, so we just call it the tram flap. And it just means that it's a transverse piece of tissue which is based on the rectus abdominis muscle, and it's a myocutaneous flap, meaning it's cutaneous is skin and myo is muscle, so it's a skin muscle flap that gets transferred. And then the microsurgical or free flap, which has become, there's a lot of internet stuff about the free flap nowadays. It's a great operation in the sense that you don't have to take the full strip of muscle and flip it up here, so it's not going to hurt as much. But it's also a longer operation. It's a harder operation. I think, just because you can do it, should we do it? The other one is just as reliable, if not more reliable. And it has something called the all or none phenomenon with microsurgery, in that when we flip the muscle up on what we call the pedicle, the standard pedicle tram flap, we've got a strip of muscle which has an artery and vein in it, and we sort of flip it up and tunnel it up into the chest. The circulation is never disrupted. We never have cut the artery and vein. The circulation's intact, so what you're looking at is generally going to survive. In the microsurgical procedure, it's completely, and that's why it's called a free flap, is it's freely removed from the body. It doesn't have circulation. Then the circulation has to be reestablished microsurgically. That means that there's one artery and one vein about the diameter of the lead in a pencil, so it's small. Those two vessels are the only thing keeping that big piece of tissue alive. Now gradually as it heals, other blood vessels grow into it, and it's not relying solely on that pedicle. But in the first week after surgery, that entire block of tissue is living on just a 1.5 millimeter artery and a 1.5 millimeter vein. And so if you get a clot or a kink, the whole reconstruction dies. The whole piece of tissue dies. And so it's what we call the all or none phenomenon with microsurgical reconstruction. And I'd just soon not take that risk, because there's always an inherent risk that it's going to happen sooner or later, where it's not nearly as likely with the belly flap, with the pedicle flap. You got to start over again and do something else. Either a latissimus flap with an implant, or you just abandon it and put in a tissue expander. It's very rare, thank heavens, but it can happen. It's just like plane crashes or car accidents. I mean, they happen, and you just got to pray that it doesn't happen to you. But every single time you do a case, every time I do one, you're always thinking, oh, I hope this isn't the one. And it's very, very stressful. It's extremely stressful surgery, and it's the kind of thing where it's great to do in sort of the bigger medical centers where you can have the residents running around checking on it every couple of hours, because in that first couple of days after a microsurgical transfer, and I do lots of them for other things, for people who get an extremity crushed in a motorcycle or car accident, then we have to transfer, say, a piece of latissimus muscle to cover up the exposed bone, and you have to transfer it microsurgically. Those are very, very stressful surgeries, and if I had my choice, I'd never do one again, but you have to sometimes. And it's, it kind of keeps your skills honed doing them every once in a while, but they are tough operations. So this is kind of just the idea with the latissimus flap transferring it over. I don't want to belabor the true mechanics of it. Like I said, the advantages of a latissimus flap, it's very, very reliable. The artery and vein that go to the latissimus muscle are very big, very, very reliable. Even in smokers, that tissue will survive very well. It's a fast operation because it's, you make a little cut here, dissect the muscle out, flip it through. It's just not nearly as much it doesn't take as long to close. You're all in sort of one surgical area, and it's less painful because you're not messing around with the belly. Disadvantages, again, you usually need an implant because you don't have enough fatty tissue on the back. Your ability to do a pull-up is a little bit weaker because you've taken that big latissimus muscle. And it's not good for a bilateral reconstruction because bilateral latissimus muscles mean it's really going to take a lot away from the patient's ability to pull and do those types of things. Now this is I'm not sure, this is out of sequence because this is a bilateral belly flap, but again, this is one of those I said, why'd you put that one in there for? But anyway, but it's good though, because then I look at it, I think, well, this is the kind of thing that people really do need to see, because when it shows, again, this is the early scars. So it's, it's kind of distasteful at first until the scars fade, and they all do. Gradually they fade. It may take 6 months or a year, maybe even a little bit more, but it does happen. But also there's no nipple reconstruction. It just doesn't look it. I mean, once you do it, once they fade and you do a nipple reconstruction, it's like, oh, it looks so much better and I feel so much better. But this kind of thing to me is unsatisfying. There's a lot of patients who will say, I'm fine with this. It's all I want. I just want to be able to, put my clothes on and feel okay. And that's okay with me. It's none of my business what somebody wants. But to me, it's not complete. And so I say, well, you sure you don't want to do this? But if not, then I'm not going to bug the patient about it. But anyway, this is a bilateral belly flap. And one of the things that you can, and if you could sort of in your mind's eye just imagine that this scar has faded, you can get very, very nice sort of droopiness to the breast and really a very natural look to the breast using a belly flap. Which is really one of the nicest thing about doing a belly flap reconstruction. And this is just sort of showing how you take the muscle, or one of these muscles gets flipped up and sort of it's supplying the blood supply to that tissue. And on a bilateral, like that previous patient, the one segment of tissue on one side is being supplied by one muscle and the other to the other side. But that's also a big hit to the body, taking both rectus muscles. So again, I generally don't like doing it. And unless somebody's had radiation to both sides and we know we can't stretch the tissue out, then I'll usually do then you kind of have to do a flap reconstruction. But again, in those instances, when I have to do it bilaterally, I usually do it microsurgically because you can keep 90% of the muscle there and only take a 10% little strip of muscle and microsurgically transfer it. The advantage is it's the gold standard. It's got a natural look and feel, and they get a free tummy tuck out of it. And patients really like it. I mean, initially it's not fun. I mean, you hurt, but 6 months later, most patients say, "Well, I'm glad I did it. I'm glad it's over with." But it's looks and feels very good right now. The disadvantages, again, long operation, painful. It's a little harder to do a sit-up. With one, it's not so bad. With two, it's very bad. It's really hard to sit yourself up if you had both rectus muscles taken, again, which is why it's essentially an operation I don't do anymore. If I'm going to do a bilateral with tissue, I do it microsurgically. And this is another example of a reconstruction. Now this was one where the general surgeon tried to keep as much tissue as possible, and so there's just a little patch of skin that was taken, or that the general surgeon took. And so when I'm watching what they do, we mark out, and so I'm going to take that much skin, but then all the fatty tissue underneath it. So you kind of carve the tissue or sculpt the tissue into what best looks like a breast, and so it transferred up here. So we were able to get, and this woman was pretty large-breasted and decided she didn't want to get a lift or have the other side lift or reduced. So we had to get, fortunately she had enough tummy, but now she got a nice tummy tuck out of it, and all that extra tummy stuff is now up in here, and it's a very nice reconstruction. And that's, and this is also after her nipple reconstruction. So once that fades, I mean, that's and that's what we're shooting for, and that's, a good, it's sort of an average result at this point, that most patients will, when we do a belly flap, you can sort of trick the body, so to speak, whether it's through, there's another procedure that I didn't mention is doing what's called a supercharging of the flap, which is where you can take some vessels, and as you're working, you identify little arteries and veins, and you can even though it's based on the rectus muscle, you can supercharge the circulation by microsurgically sewing some of the vessels of the flap into something on the chest wall to boost the circulation. Microsurgery, I just went over, same as the pedicle, the same advantages. One of the reasons we may have to do a microsurgical procedure is if patients had an old-fashioned cholecystectomy where they make the big scar underneath the rib cage. Nowadays, thank heavens, everything is done laparoscopically, so it's rarely a concern. But in the old days, when people would have the big open gallbladder procedure, they would cut through the muscles, or if, say, they had their spleen out and they'd cut through the muscle. You can't flip it up because the blood supply traveling through that muscle has been divided by definition from a prior surgery. And then the microvascular thing, again, it's kind of a cool procedure, but it's sometimes, most of the time, just not worth the stress. I just save it for when I really have to do it. The buttock flap had gotten some popularity for a while, but not too many people do it anymore because it was just like so many things in plastic surgery, which is kind of embarrassing, is we just go through these phases of gimmicks, and that was, the buttock flap was one of them for a while, where it's like, oh yeah, I can do this. I mean, you could transfer somebody's finger up to their ear if you want to. It's like, well, why? But somebody could write a paper on how they did 50 of them and they all lived. Well, so what? There are reasons to do things and reasons not to. The buttock flap, very often everybody thinks, oh sure, I've got plenty, but you really don't. It's really hard to build a breast out of the tissue from the buttock. You got to sit on it every day, so it hurts more post-operatively. And the vessels to the tissue in the buttock coming off the superior or inferior gluteal artery, and again, I don't want to get too anatomic on you, but there are identifiable vessels which you can find going into the tissue, so you dissect down. It's almost like when you dissect, so you can take a tree and you take a bunch of branches and you narrow it down, and as long as you keep everything intact, you can trim all the other branches away and keep that one segment of tree alive. We're doing the same thing here. The buttock flap, obviously there's nothing that allows you to pedicle that up. You can't sort of stretch it up here. So that has to be transferred microsurgically. And the vessels are very small and very short, so very often you need to take a vein graft from the leg and sew that into the vessels on the chest, and then the vein graft into the buttock flap. So that's a procedure that really is has kind of died. And this is the disadvantages. I've just gone over that. There's a volume problem. You probably need vein grafts, and again, you have that all or none phenomenon. And the other is the tissue physiology research from the plastic surgery standpoint, that there are little things that we can do, adding things. There's something called heat shock proteins that are getting a lot of press in the plastic surgery scientific literature about being able to literally inject their proteins that they were found that, for example, if a patient were to get burned and then a week later need a kidney transplant or have some other surgery by some strange coincidence, the patient always did better. Somebody who had a prior injury always did better on that operation that they subsequently had than on your average person who just came in and had their gallbladder out or appendix out. And so there was something about the body when it's stressed, and they called them heat shock proteins because they first found this in burn patients, but it can be with other types of injuries, but they've been called HSPs, heat shock proteins, that we've been able to isolate in the bloodstream. And I actually was doing some research with HSPs in my lab in Wisconsin before I moved out here, and we were demonstrating that if you could inject small amounts of heat shock proteins into a flap of tissue before you microsurgically transfer it, you can actually transfer twice as much tissue, because it does something to the blood vessels, and we don't know yet what it does, but there are little tricks like this that we're learning. Unfortunately, it's still in its infancy, and then you have to isolate these proteins and clone the gene and make them, and they're going to be very expensive. But at some point, well, we'll be able to do very big and fancy reconstructions through very small incisions, as well as doing the mastectomy or doing the breast removal through very small incisions. And that's it. Those are my kids. Any questions?
So join me in welcoming Shar.
Thank you. And if and when I go on my cruise, I'm not calling anybody. So today what I would like to talk about a little bit is some of the fact and fiction of breast cancer. There's a lot of misconceptions and what do I want to say? I want to say like a mistruths, but that's not coming up. Misinformation out there. So maybe we can clarify a little bit of what we need to believe, what we need to not believe. One of the first myths out there, and it's been talked about already, is, sorry, I got to get used to this, that only women get breast cancer. We have talked about the fact that men do get breast cancer, and there'll be approximately 2,000 men in the year 2008 that will be diagnosed with breast cancer, and that accounts for about 1% of all the breast cancers. If a man gets breast cancer, the prognosis is the same as for a woman. The treatment is the same, except for rather than being offered a lumpectomy, usually because they don't have enough breast tissue to do that, they usually will have a mastectomy. But men that do present with a lump to their physician, they will come over to the Broadway Imaging Center and they will have a mammography just like you and I do. So if you think it's uncomfortable, try and do it on a man. But they do it, and they will do an ultrasound. They're offered usually a mastectomy. They may need chemo. They may need radiation, most likely. The difference with their survival rate versus women is that a lot of men tend not to go to the doctor. And if they find a lump, they just kind of discount it. We've got it embedded in women to pay attention to your breasts. If there's a lump, to go get it checked out. Men don't think like that because they don't think that they're going to get breast cancer. So it tends to present at a higher stage, like a stage 3 or a stage 4 versus a stage 1, where it could be more curable. The second myth is that only women with a family history are at risk. And we have definitely proven the fact that no. If you have a family member that does have an increased risk of breast cancer, or that has breast cancer, you are at an increased risk. That doesn't mean you're going to get it. And 80% of most of the women that are diagnosed with breast cancer do not have any history of breast cancer in their family. That may typically mean their first-degree relatives, maybe their aunts, their mothers, their sisters. There may be some farther out, maybe a cousin, a second cousin might have one, like Dr. Snyder pointed, that just does not really factor into your risk of getting breast cancer. Most breast cancer is genetic. We talked about only about 5%, 5 to 10% are due to the abnormal genes. That abnormal gene is found on chromosome 17, and there are 2 of them called the BRCA1 and BRCA2, which took me about 2 years in my position before I figured out that the BRCA meant breast cancer. I thought it was some scientific word, when in actual fact it's breast cancer 1 and breast cancer 2 gene. 2 myths here: older women don't get breast cancer and younger women don't get breast cancer. I don't know, I still consider myself young, but my kids consider me old, so I guess I'm not quite sure where I come into this, but here's some statistics as far as the age, how it pans out. Under 30, roughly 1 in 2,200 women will probably get breast cancer. By age 40, that decreases or increases significantly, 1 out of 235 women. It's a huge jump just in 10 years. Another huge jump by the time you're 50. A lot of the breast cancers that we're seeing are in women in their 50s and 60s. Definitely not out of the by the time you're 70 and 80, you're still not out of the woods as far as breast cancer. Women by the age of 80, they're about 1 out of 10 get breast cancer. This kind of equates to, out of our lifetime, 1 out of every 8 women will be diagnosed with breast cancer. I've heard this a couple times, and the first time I heard this, I was like, excuse me, what? Breast cancer is contagious? It's not. You can't get it by touching someone, you can't get it by drinking their water, you can't get it by being in a group of women. There's nothing contagious about breast cancer at all. Coffee, caffeine causes breast cancer. That has been disproved. It does not cause breast cancer. We can continue to enjoy a morning cup of coffee. I can't be responsible for anything else that it causes problems with, like heart disease or weight if you use cream and sugar, but as far as breast cancer goes, enjoy your coffee in the morning. Antidepressants, yeah, we need those. They don't cause breast cancer either, but they sure help you deal with it. Antiperspirants and deodorants cause breast cancer. This has been out there for years, and it keeps resurfacing all the time. But they have done numerous studies over this, and they have proven time and again that it does not cause breast cancer. The 2 major leading manufacturers of antiperspirants or deodorants both have done their own studies along with other independent studies, and they have found no specific link to it. Pesticides, lawn chemicals, dry cleaning services, can they cause breast cancer? This is kind of one of those areas where you're going to have one study that's going to prove one of them will cause breast cancer. Another study is going to come along and disprove it. I have a personal opinion that it doesn't help. I suspect with everything else out there, that's probably just another piece of it that's going to add to our increase of getting it. Truthfully, I don't think they can say by having your lawn sprayed that's going to cause you breast cancer. Maybe in the whole range of everything else of our environment, it's probably going to help contribute it. These will continue to be ongoing. They're going to continually be looking at these types of pesticides and stuff like that just to see. But right now with the medical community, anytime they prove something, there's something that comes along and can kind of disprove it. Breastfeeding causes cancer. I've heard a lot of women say that, when in actual fact that it tends to decrease breast cancer. The theory behind this, like Dr. Snyder talked about, was estrogen, cancers that are estrogen positive and they're fed by estrogen. In the olden days, women had babies, 10, 20, 30 babies. I mean, I don't know how they did these families, but they were pregnant all the time. And they didn't have bottle feeding, so they had to nurse. And basically what happened is the body got an estrogen vacation. You didn't make estrogen when you were pregnant nor when you were feeding. So because of those little vacations, your body was subject to less estrogen, there was less breast cancer. Then with the onset of bottle and people started not breastfeeding their babies and having less children, our bodies don't have much of an estrogen vacation as what, say, our grandmas did, or in my case, my mother did. So the theory is that if you do, giving those vacations helps decrease the risk of breast cancer because your body is not exposed to estrogen for as long as someone who maybe has never had any children. So breastfeeding does help decrease the estrogen in your body while you're nursing your babies, and so it does in fact help reduce the risk of it. Doesn't mean you're free from, you never have to worry about it. It just decreases your risk. Birth control pills cause cancer. This one's been out there for a long time, and they've done numerous studies on it, and it has proven that it does not cause breast cancer. There again, even women that have prolonged use, if nothing else, they tend to have a decreased risk towards breast cancer because there again, it decreases the estrogen production in the body. Underwire bras cause breast cancer. I think this one came out in the 60s when they started everybody burning their bra. But when in actual fact, there's no link at all, so you can wear whatever you want. Small-breasted women cannot get cancer. I'm not quite sure where this one comes from, because if men can get breast cancer and they have a lot less than women do, women can get breast cancer no matter their size. If you have breast tissue, you're eligible for breast cancer, basically. It doesn't make any difference the size of it. A mammogram prevents breast cancer. It does not prevent breast cancer. It is our best tool that we have to date for detecting breast cancer, but it does not prevent it. Nor by the same token does it cause breast cancer, because it is a very low dose of radiation, and hopefully we only get them once a year. We don't have to come back. With the low dose of radiation, it's really not a risk. And then you also have to kind of look at the risk-benefit. The risk of having the low dose radiation for finding the breast cancer is far greater than the risk that it would cause breast cancer. An injury to the breast causes breast cancer. This one came up a lot of times when I was working in radiation oncology. Women would come in with breast cancer and they would say a log fell on their breast, or they were hit in the breast or something, and then 8 months later they had breast cancer there. Studies have proven over and over again that injury or trauma to the breast does not cause breast cancer. Breast cancer typically takes about 8 years to develop before you're able to feel it at 1 centimeter in size, which is about 3/8 of an inch. Basically starts out when one cell goes bad or goes wild and starts its doubling process. And a cell can double anywhere between 29 to 220 days. So each one, it takes a while for that. These cells are microscopic, teeny, teeny, tiny ones. It takes a long time for it to develop to where you can feel the lump. A lump is always breast cancer. Dr. McKay talked about the fact that the majority of the lumps that they do mammogram or sonogram on, or even biopsy, are not. And 80% of most of the lumps that when people present here for a mammogram, they are not cancerous. A painful breast lump is not cancerous. He also did say that breast pain is not cancerous. There are some breast lumps that come in and people will say that they can feel them and they do hurt. So about 10% of them are associated with pain, but that's usually because the lump is large enough, or maybe where it's located, it can be causing pressure on other tissues and it can be painful. But majority of the breast pain that we see is not related to cancer. It's a very frustrating problem that we have in dealing with women, because it's very hard. It's a matter of trying different things to see what will alleviate the pain, and it's trying analgesics and that might not work, so then they have to try warm compresses and that might work, and what might work for one won't work for another, and it's a very frustrating problem that women do have, but majority of breast pain is not breast cancer. Lumpy breasts are also called fibrocystic breasts. They are at increased risk of cancer, and that is not true. Fibrocystic breasts consist of your cysts, your fibroadenomas, like what Dr. McKay showed us this morning, lumpy breasts, areas of thickening. Sometimes we can get increased breast tissue in different areas of our breast, and it might feel a little bit thicker than the other one. Tenderness and breast pain. Lumpy breasts are, surprisingly, if any of you, I presume all of us, let's assume all of the women in here do self-breast exams. You all know that your breasts are very lumpy. There's nothing smooth about them. And we encourage doing self-breast exams so you get used to feeling what they feel like, to know that they don't feel smooth, so that if there is a lump or if there is a change, you can be aware of it. All fibrocystic change is benign, and they make breast cancer detection more difficult because usually fibrocystic breasts are denser and it's harder to pick up on mammography. In this cases, they can use ultrasound, and sometimes MRI is also a very good tool being used. However, MRI is not used for screening of breasts at this time. It's usually used after a woman's already been diagnosed with breast cancer. Then they'll do an MRI of both breasts to see how the other one is. It is a very good tool, but it's also very expensive, and it's just not really appropriate for screening at this time. Nipple discharge indicates breast cancer. Majority of nipple discharge is not cancerous. There is one where if you have a bloody nipple discharge, usually it's a small tumor called a papilloma, which is benign. Any nipple discharge, whether it's out of one nipple or both nipples, should be checked out by your physician. A negative mammogram means that you don't have breast cancer. We come back to that kind of fibrocystic breast disease where your breasts are really dense. Mammography is not perfect. It does miss 10 to 15% of all the breast cancers. That may be picked up on ultrasound, or in a younger woman, if they have a lump that doesn't show up on mammography, they may recommend that they do have an MRI if they're suspicious. 21% of the cancers last year that were detected were those microcalcifications that Dr. McKay showed us this morning, and I do have a picture of them. They look like little tiny pockets of salt, I guess, and about 21% of these can be cancerous. Women don't feel them. Most of the time they are totally unaware that they even have them. In this particular case, this is where mammography is an excellent tool because these show up very clearly on mammogram. Those are some of the myths that I've talked about, but I want to kind of talk about some of the symptoms also of breast cancer, what to kind of look for, because I've kind of told you what doesn't cause it, but some things we need to be aware of. If one of your breasts becomes very painful quickly and has a rash to it, or if it becomes quite larger than the other one, as most of our breasts, we already have one that's larger than the other one if you really look closely at them. If you've never really paid any attention, you might be kind of surprised to realize that, one's bigger than the other. That's normal. But if you notice a sudden increasing size of one, or if it becomes painful and it becomes red or with a rash, you definitely need to have that checked out. Any dimpling, any pulling on the skin that might cause a little dimple needs to be checked out. By the same token, any bulge in the breast needs to be checked out. Any discharge from the nipple, we'd like to have any of that checked out, but more importantly, if it's out of both, it tends to be more benign. If it's just out of one, really need to have it looked at. Inversion of a nipple, if it's normally everted and it suddenly starts to invert on itself, that needs to be checked out because that could mean there's something underneath the skin pulling that nipple back. Itching, irritated, or a scaly nipple, sometimes women get that without any discharge and it just doesn't go away, needs to be checked out. These are all signs that they could be breast cancer. And any changes in the vein patterns. Again, if you look at your breasts, you'll notice you've got some superficial veins there, and most of the time they're very easily seen. If you happen to notice that one is suddenly larger than the other or becomes maybe protruding or something, if it's a very blatant change, needs to be checked out. Our best tools right now are yearly mammography. We encourage all women of all ages to have them. I've had a lot of women say that their doctors have been telling them after 65 they don't need them, and that's not true. We know that we need them basically for the rest of our life. Clinical breast exam, should have one once a year. If you see your physician, he or she should be doing one. Sometimes they can pick up a lump that maybe you didn't feel. Maybe it's just because of the different technique, or maybe you're like me and don't faithfully do your breast exams every month, which I'll admit I don't. But I do them, just not faithfully every month. But we should do them because a lot of times the breast cancers are picked up by women who do their own breast exam. Oh, see, and I have that here. 25% of all the breast cancer, or the lumps that were found that were breast cancers, were found by women themselves, or their spouses or their partners found the lump. 35% are detected on mammography alone, and then 40% usually can be seen and felt on mammogram. So early detection definitely is the best protection. Anytime we can catch cancer as early as possible, the bigger chance of cure that we have, and that's our whole goal here. Any questions?